I wanted to officially welcome everyone today to our Works in Progress series hosted by the FXB Center for Health and Human Rights. My name is Maggie Sullivan, and I'm one of the postdoctoral fellows at the FXB Center, and I'll be moderating today's session. And today's topic is titled The Chelsea Project, the Alchemy of Science, Policy, and Community. And I'm really pleased to introduce or reintroduce for those of us at the FXB Center, Cristina Alonso, who collaborated with the FXB last summer on her research. And Chris is a fellow clinician and a midwife who recently graduated from the DRPH program here at Harvard Chan. And her doctoral project focused on understanding the impact and social response to COVID-19 in Chelsea, Massachusetts. So just to let folks know about the format for today, Chris will start and briefly describe the Chelsea Project and what it is, and then the panelists will introduce themselves and their unique roles with the project. And then I will ask the panelists a few specific questions just to get us started, and then we'll open up the discussion to everyone. And just to set the scene, as many of us know, Chelsea is a really small area consisting of about 1.8 square miles just outside of Boston, and it's home to about 35,000 residents. And it's also home to one of the highest shares of immigrant and limited English-speaking residents in the state. Chelsea, as a lot of us also know, was among one of the areas hardest hit by COVID-19 in Massachusetts, which was largely attributed to several factors, including crowded housing, very little opportunity to work from home, few workplace protections, and I would also say low confidence or trust in public health systems, especially after recent years of increased immigration enforcement. I'm sure several other factors as well, and we'll hear about that from Chris. And so I'll turn it over to Chris now, who will tell us about the Chelsea Project and how they brought together a really dynamic interdisciplinary team to address the pandemic in Chelsea. So welcome, Chris.
Thank you, Maggie. And thank you to the FXB Center and everybody who's there. First of all, for supporting my work, my doctoral work in the summer and the fall, and also for giving us the space to talk about our work. So I'm going to share my screen. And here we go. All right, so there's 5 of us presenting today, 6 of us, 5 of us, who are sort of the different arms of the Chelsea Project. And I think what's been fun and unique for me, and I think for all of us on this project, is that it really embodies what a lot of us love about public health, this intersectionality and this multidisciplinary approach. So, you know, this little wheel is kind of like a visual map of our thinking or of the design of the Chelsea Project. And really the idea is that you can take all of these pieces that came to the forefront of pandemic response, and if you put them all together and you put everybody in the same space to talk about, you know, how all of these issues not just influence each other, but how they can be improved. And so on one hand, we have sort of like the bench science, you know, we're monitoring the wastewater. We've been monitoring the wastewater in Chelsea on a weekly basis at 4 sites. And so we're able to see where the COVID rates are going up. And we know this before the actual rates in the testing results come back positive. So we've been able to predict where the next area of Chelsea is going to have an outbreak or, you know, a surge of COVID. And this is important because, as Maggie explained, Chelsea is very densely populated, and the people that still have jobs, which, you know, fluctuates a lot, but those that do are essential workers. And so we know that we've been able to, you know, I'll talk in a minute about, so then what do we do with that information? But it's given us, you know, in terms of Massachusetts and technology, we've been able to know this is where it's going. And we've seen the neighborhoods change over the weeks. The other thing that we've been able to do is partner, both on a local level with local organizations, with the city government, and also with the state government and also with other cities. And so one of the things that happens at our meetings is, you know, we will have Barry will talk about, oh, well, this is what Revere's doing. This is what this other city, you know, this is, they tried this in Broxton and it didn't work. And so having that lived experience, because we can't wait for papers to be published. A lot of us that are in the field don't actually have time to publish papers. And by the time a paper is published, it's usually 3 or 4 months after the work has already been done. Other work that we've done in terms of partnerships is partner with other organizations in the country. So for example, one of the organizations we really looked at was in the Mission District at the beginning of the project, because they had taken on a Latino response when they felt that the Bay Area public health departments weren't really addressing the needs of the Latino population. And knowing that Chelsea is 67% Latino, we looked to them for how did they do it? What did they learn? What are the things that they learned quickly not to do, so that we could take that experience and replicate it. So then the other thing that we just started doing was, okay, now that we have all of this information, how do we start landing that in Chelsea? And one of the things that I had done for my doctoral research was case analysis of the positive COVID rates in Chelsea. And so I had an understanding of what had happened with the pandemic over the summer. And through our negotiations with the Chelsea Project and the city of Chelsea, we were able to get access to the positive database, and we continue to do that. So month by month, we've been able to see the disease distribution in Chelsea, and therefore make recommendations both at a state level and at a local level. So for example, when we were talking about vaccine rollout, we already knew in Chelsea that the pandemic was in essential workers between 30s and 40s in those 2 decades. And we knew that since August, because in Chelsea, what happened was the disease distribution first started in the older population, but then it quickly migrated into essential workers. And it stayed in there. So when we had the second wave in the fall, in the winter time over the holidays, we were really looking at essential workers being the most hit, and then non-essential workers being the second most hit. So what we were doing starting January was really pushing for vaccine eligibility to be open for people who were younger, because we were arguing that in Chelsea, the eligibility for older people was important and it was good, but really we weren't going to start addressing the actual pandemic in Chelsea and its economic impact until we started being able to vaccinate essential workers in their 30s and 40s. What happened was that once the city of Chelsea started having FEMA clinics, we actually pushed to open full eligibility a couple of weeks before the state did. And if you look at the, we'll look actually at the vaccine numbers, but there's a very concrete increase in the rate of Latinos being vaccinated that coincides precisely with the FEMA clinic opening up, which means that when we push for increased eligibility, all of a sudden Latinos were being vaccinated. And we have really good vaccination rates among the Latinos in Chelsea, which actually are better than Boston's. So, you know, this is sort of like on the ground, constant decision-making and a data-based approach. And then the last thing that we do is we intersect with the community. And we knew that, you know, because of everything that I'm sure everybody here knows, is that specific communities of color need specific interactions and conversations with people that they trust. And so there, what we did was we started working with La Colaborativa. We work a little bit with Green Roots as well. And we have a team of 10 health promoters. And what they do is they get trained every Monday on different issues. We call it Gossip Circle. And what we do is we come together and the health promoters tell me everything that they've heard that weekend about COVID. I heard that they're going to put a microchip. I heard that if you're allergic to pollen, you can't get a COVID vaccine. I've heard this, I've heard that, I've heard this, I've heard that. And then what they do is Wednesdays, Fridays, and Saturdays, the health promoters are going door to door, or they're in specific locations around the city of Chelsea, giving people information and also giving them appointments. One of the things that happened early on with the vaccine eligibility was that for the state of Massachusetts, people were expected to make vaccine appointments either online or making a phone call to the East Boston Neighborhood Health Center. If you're an essential worker and you have to wait on the phone for hours, or you can't actually use your phone while you're at work, it's not very relevant. So we kept pushing for some sort of backdoor way that on the ground, we could start making appointments for people. And the way that we solved that was just directly making them on the street. So now what happens, health promoters, they get the information from the person who wants the vaccine. Often that involves a conversation of, well, you know, this is what happened to me in my health history in my life. Can I get a vaccine? I'm scared about this or that. And at this point, the health promoters are really well trained on being able to handle those conversations. Then they text me with the person's information. I give them a backdoor appointment at either one of the two vaccine centers. And then that person leaves that conversation knowing exactly when they're going to get a vaccine. So this has been really, really effective in solving the micro parts of vaccine access. So this is sort of like an overview of everything that we do in the Chelsea Project. And we come together on Fridays and we talk about what we're doing. And that gives us a time to listen to what each one of us is doing, give each other advice, troubleshoot ideas, think of, okay, so where are we going next? This is what's happened this week. Let's look at the data. What do we do? And so collectively, we can also come up with better solutions than if we were just one person or one group doing one part of this whole puzzle. So this is just an idea. You know, I didn't want to create one of these crazy slides that's full of thousands of logos, but do think of this as a very busy slide, because this is everybody who's involved or who has touched the project in some way. And of course, there's people missing here. And so, for example, somebody who's not here or the other organizations in Chelsea. And in the city of Chelsea, I would add the pandemic response team who we worked with, especially in the fall and the winter. Now that's kind of moved on. We have worked with the Board of Health, presenting to them information. And now we've worked closely with the eviction task force, because the next step of, well, you know, the current crisis or the humanitarian crisis where we are right now in Chelsea is definitely in the eviction situation. We also worked with Envision, and I'm mentioning them because Tariana Little, many of you might also know, she's also a DRPH graduate. She has a media company, and she helped us when we knew that vaccines were going to be rolling out. She helped us make videos with leaders from Chelsea in Spanish and in English that address the common concerns of vaccine. And those videos have been very effective at getting people to know that if these leaders give us permission, if they, you know, say that the vaccine is good. We had Father Edgar, who's maybe sort of like the most powerful spiritual leader in Chelsea. We had Gladys Vega, who's the director of the collaborative, and we had a physician from MGH who's a Puerto Rican, so he's Latino, talk about these. And so these are ways that Chelsea residents can relate and say, okay, so if Gladys says the vaccine is good, if my priest says that the vaccine is good, if my pastor says it's good, then I trust. These are people that I trust. Also, you know, I mean, just so many people that I don't want to get stuck on, but I think one of the interesting things about this project is we've all brought with us people that we know are going to be not just useful, but strategic in how we create an interdisciplinary response in a city that was so hard hit and that was already starting from such a vulnerable place. So this is just sort of, we wanted to show you a little bit of what is the information that we use and how are we making decisions. So this is a graph of the wastewater monitoring. And here you can see the 4 different sites where we are checking the wastewater. And you'll see that, for example, Crescent, which is it's kind of like the center area, the downtown area of Chelsea. That part was the hardest hit at the beginning, and you can start to see the blue line starting to drop off. And then we see Spruce going up. And if you go to Spruce in Chelsea, it's kind of, if Chelsea's already poor and vulnerable, Spruce is kind of like the poor and vulnerable part of Chelsea. It's a difficult area, and kind of maybe the story behind this is people starting to go back to work and bringing COVID back, overcrowded housing, et cetera. So for example, during January and February, we really focused on making sure that the health promoters were going to the Spruce area to let people know there's COVID here, please go get a test, et cetera. At the time, we were working with MGB, with Mass General, who was having a van that was going every Tuesday to, first it was going to La Colaborativa, to the food pantry. We realized that wasn't working so well, so we decided to move it to Bellingham Square, which is where all the buses stop. And what we did was we had the health promoters be there, and they would basically tell people as they were getting off the bus, come get a COVID test. We're doing this, you know, get some masks, get some hand sanitizer. And that started working really, really well. Now what's happened is that the MGB vans are now shifting to add-on vaccine vans. So now what we're doing is we're accompanying them when the van goes to different places. They went to the park, they've gone to the parks, different parts of Chelsea. And we actually had a vaccine party on Friday. So what we did was we really wanted to target the youth, because we know, and I'm gonna go to the next one, because we know exactly how many people are being vaccinated week by week and how well our numbers are doing, we were able to know that we needed to target especially people from 12 to 29 years old. So we decided to have a party, and the MGB van came to La Colaborativa. We had the health promoters working, we had the media there, we made a lot of noise, we danced, we had pizza, we had food, and we just had a wonderful celebration, which also addresses other issues in health, which is healing and celebration and just being able to come together and have a good time, while we vaccinated 120 people who will come back in 3 weeks for another party and for their second dose. So these are just some shots of the work that La Colaborativa promoters are doing, just to give you an idea of that. So for example, when they're at Bellingham Square, one of the things that they'll do is they'll go to the shops around Bellingham Square. And for example, you'll see this picture here of Judalis at the barber shop, and she's talking to the guys at the barber shop and saying, you know, did you guys get vaccinated? Do you have any concerns? What do you think? Are you gonna get vaccinated? Can I get you an appointment? The one right next to that is the health promoters at the party that we had on Friday. And Dr. Julia, who's here, has actually come with the health promoters on Saturdays to, you know, have the presence of a medical doctor. She's brought other physicians from MGH to come and sort of, you know, help with the information that residents need. And we found a really wonderful response to that. So I'm going to pass it now to Sam Bates, who's the director of the Center for Complex Interventions. So you can introduce yourself.
Yeah. Thanks, Chris. So that was an amazing overview of all the things that we're trying to do. Whenever we go through all of it, I'm like, oh, wow, there's a lot of different aspects of this project. Yeah, so I'm the executive director of Center of Complex Interventions, which is the funding organization for this project. And my role on the team is more on the operations side. So I manage the budget with Barry, and you know, every week on Friday when we discuss how the project is going, you know, if there's any expertise CCI can provide, I am that contact. So I'm really happy to be here and excited to talk more about the work. And I'll pass it off to Karthik to introduce himself next.
Thank you, Sam. I'm a clinical medicine and machine learning researcher at MIT, and I work pretty closely with CCI as well. This project, ever since it started, funnily enough, the way it started was a conversation between Dan Cortez, who's also here in the panel, and us almost a little over a year ago, because Chelsea was just experiencing a lot of high COVID cases. And what's really stood out for me as a researcher is all of the ideas that were going around early on with regard to some of the technical things we could do. Pool-based testing to increase the number of people getting screened for surveillance, rapid antigen testing, deciding what vaccine priority should be followed, the way the wastewater monitoring for SARS-CoV-2 was instrumented. You know, we read these papers often and it seems as if they can do a lot, but then you walk around and talk to people on the ground in places like Chelsea, and you just realize that all of the sterile clinical guidelines, you know, being issued in good faith, both by the state and entities like the CDC, the lived reality and the lived experience for people on the ground is something totally different. And so what is very striking to me about this project is the complexity of combining the technical package with on-the-ground partnerships and collaborations, like Chris said, and seeing it operationalized and seeing it produce results has just been so inspiring. And I'm just so fortunate that I am a part of this team. With that, I will hand it off to Dan Cortez.
Hi, everyone. My name is Dan Cortez, and thank you, Karthik, Chris, and Sam, and soon to be Barry. I think I'm the guy that's walking on the street and the bag of money falls on his lap and he tries to figure out what to do with it, because all, you know, this wealth of knowledge, these really incredible people, I've had the I've been blessed to interact with. I first met Karthik when they did an analysis of the Chelsea Hub model, which is a group that gets together every week. It's a bunch of service providers that take a look at really at-risk individuals and immobilizes resources, does an intervention, and then we report back to each other every week. And the reason why that's important is that, to me, is that it's really reduced the level of risk in the city. At one point, we were the 11th most dangerous city in the United States, and we're out of that top 100 ranking, #1 in the state, down to 23. So for me, what that taught me was, if people communicate on a regular basis, get together frequently, share information with each other, you're going to have a bigger impact than if you try to do it on your own. And so when Karthik reached out, I thought, what you're offering is great, but you really need to be talking to, Mimi Graney, who is the head of the pandemic response team, and then eventually to Barry Keppard, who is getting together, a bunch of communities in the North region, because they really need to hear from you. And that's where the relationship really started. So for me, I'm more of a connector of sorts. And, with my work, doing engagement work in the city, I'm able to connect, this team with other individuals. And I'm also, in a position where I can, advance certain issues, like my relationship with, our city manager. That's been really important. But anyway, that said, I'll pause for now and pass it on over to Barry.
Thanks, Dan, and thanks everyone else too. So again, to echo something I think Sam was saying earlier, just overwhelmed by the work presented that way, Chris, and definitely humbled to work with Dan and Karthik and everybody else. It's been really awesome. So I am the director of the Public Health Department at the Metropolitan Area Planning Council, which is the regional planning agency for Metro Boston. I'm actually an urban planner by training, but I act like I'm somebody in the public health field. So I'm typically an imposter there, but glad to be in that field. But it's really, really exciting to be in this role. I think to what Chris alluded to earlier, since you've been helping to kind of be a bit of a conduit from other examples within the kind of the metro area to Chelsea, for us to think about that, learning from places like Revere and Somerville and other places that are doing work like that. And similarly taking what we've learned and what we're trying to do here, because some of this does require policy change. Some of this does require looking at information differently or making leadership decisions differently and trying to lift that out to other locations. Really with kind of Karthik's guidance and leadership have really kind of helped really work on the wastewater piece of the work too. And so kind of trying to bring that to bear, and to Chris's point, make it active every week. And then I think to Dan's role, it's just like, it's been really incredible to kind of be a partner along with him to see how those connections can really facilitate, whether it's the videos, whether it be the organizations we're working with, the residents that we're working with, and all the work as well too. So really just a team effort all around. And I suggested the title of the session back to Chris and the team of the Alchemy piece, because I guess to me, like, that's been the exciting part of all this too, is like, we're doing science, but we're kind of doing half-baked in a way that we're understanding it in the moment. And I think that's the thing that's really exciting. And I do think we're producing some gold out of it too. So exciting for that part of it. So I will hand it back to Chris.
Thanks, Barry. And I'll actually hand it back to Maggie.
Sure. Thank you, everybody. It's not often that at these works in progress we get to hear from such a variety of disciplines. And so I think that for something especially like COVID, this required a lot of partnership, some partnership based off of existing collaborations, but then also really being pushed to create new or evolve the partnerships that we currently have. And so I really enjoyed hearing even just how you have combined some of these technical solutions with communication strategies, and the idea of even like the idea of gossip circles, and just a place where you can bring and just open up, I think, a lot of trust of like, what have you heard? Like, tell me, like, what's on your social media feed? What did somebody say to you? What did your neighbor do or say? And just creating this safe, trusted space where you can almost like vent all of the stuff that you've heard about, and making it something that's kind of like fun and social and sharing, all the way to like having a vaccine party, which is just such an intuitive way to include young people and create some excitement around vaccines. So it's really great to hear about this, and to Dr. Julia's point, I think that this idea about what are the technical guidelines. I think, I don't know if, can't remember if it was you, Karthik, or somebody who had mentioned on the panel that there are well-intended guidelines for how communities should be responding that are not necessarily suitable to what's happening on the ground, and there's a lot of discordance between what is the way that it's landing or what is even possible in communities. And so I think that as a result, something like the Chelsea Project needs to almost have this alchemy of creation to fill that gap of what is lacking from some of our larger public health institutions. And so I wanted just to begin some of the conversation. And Dan, you started this, you started to talk, I think, a little bit about the hub, but I wanted to hear, what was it about Chelsea's response that made it possible for something like this to happen? So there's a number of communities that are made up of residents like Chelsea, but this type of project hasn't happened in a lot of places. So what were some of the facilitating and enabling factors that were already in place and made something like this possible, and not just possible, but successful in Chelsea?
I don't know if that was directed to me, but I can talk about the 1 or 2 years before the pandemic. So the city was already very connected. When I first arrived in the city about 8 years ago, it was pretty disconnected, and there were many efforts, not just the hub, many efforts that really brought the city together. It is small, it is very small, so it's easier for us to do that than a Brockton or Lawrence. So we took full advantage of the fact that we're basically a tight knit family. We even, for 5 years running, we even had a monthly taco event that a lot of the city leaders would come to and with residents. So we already had a cohesiveness. When the pandemic hit, Mimi Graney, who I think she's on the call with us, reached out and said, Dan, we need to support Tom. This is getting really bad. And so we, in 30 minutes, just concocted what the pandemic response team was going to look like. So that group met every day. That was not just Tom. It was all, heads of organizations, residents. Everyone would get on a call at 4 o'clock, and we would update each other every day on what was going on. The food distribution team, there were so many different teams that were out there really kicking some serious butt. So our response to the pandemic from the early days was facilitated by that process. And then teams started to branch out from that. And so, as we, continued through that process, we took full advantage of the fact that getting together on a very regular basis is key. Coordination and communication is key to any response. Fast forward to, when the Chelsea Project started, we realized that we needed to communicate on a very regular basis. So we actually created a Slack channel. So yes, we do meet on Fridays, and those are important meetings, but it's the 50 messages that you get on Slack from the team that really just ideas start to germinate. Ideas become things. What if we did this? What if we did that? So things that happen really fast in Chelsea are facilitated by that process versus get a group that gets together once a month and says, should we do this or should we do that? And then 6 months later, you might do one thing. We move at light speed. And I think that's what has put us where we are. I always say that every community should have some sort of a partnership that is made up of the component pieces that we have with the Chelsea Project for any issue. I'll pause there.
Yeah, I think that's, I don't know if anybody else on the panel would like to respond, but I do think that that's a point well taken, that COVID is not some novel space where, where interdisciplinary participation is uniquely needed. I think that it just highlights how much we need to be doing that for in lots of complicated and complex areas. Um, so another question that I was curious about was more along the data lines, and I guess this question is for Barry. But how has the use of data evolved over the course of this project?
Thank you. Thanks, Maggie, too. And I'll definitely invite the other parts of the team in for this conversation as well, too. But from an early stage, I think that what Chris spoke to, I think we were able to kind of get some of the wastewater monitoring off the ground early. But I'll be honest, like as that was even kind of an evolving science, we had the data, but making sense of it was something that kind of took us some time to kind of understand essentially, like, is it tracking with some of the increases that we want to see? And in the early part of it, speaking to the point you made earlier, Maggie, in terms of how hard Chelsea was hit, volumes in terms of like what we would expect to see in the wastewater was extremely high. So the volumes were comparable from like a municipal perspective to other municipalities, but in the beginning it was just a lot of noise. But it's become something over time that we've been able to read better. And I think use of data, particularly in the way, again, to Chris's point earlier, being able to direct the promotores kind of in a week by week basis from the data, just again, echoing Dan's point about the light speed, it just allows us to kind of react and move much quicker. And that's actually in really interesting ways carried forward into the vaccine data as well, too, to those particular points of it. But I will say, like, I think a huge point for us, both as a team, but in terms of data, was learning that in parallel to the work that we were doing, the work that Chris was doing with La Collaborativa, looking at some of the case data within the city of Chelsea, then became a really, really important point, because that also then informed work we were considering, partnerships we were kind of thinking about, and kind of outreach that we were doing part of it too. And I think amidst all that, having someone like Karthik was really incredible too, because as we took some of those steps forward, we had someone who was kind of helping us and looking at the science as it was evolving, as it was coming out, and some of the kind of leaders in that work, like folks like Joe DeRisi from the West Coast, who again could give us some real-time feedback too. So it was really great to be able to moving up and down the chain in terms of very, very close to the ground with the data and seeing like how true it was and what it could tell us, to all the way up to a bit more of a 30,000 foot level to see essentially some of that kind of peer reviewed work or ongoing work and what that was saying that we should learn from too. So I'll stop there and turn to the team, but it was really interesting to be able to be in a dynamic where we could work with data that way.
I'm going to jump in and say that for me, one of the things that has felt, it feels really good because it feels like it encompasses the values of public health and health equity, is being able to take this scientific data and this high level stuff and take it to people's homes that are living. They are the data, and explaining it to them and making it in less than a week. So by Wednesday, we knew what was going on in terms of the wastewater and in terms of, and once we started vaccinating on Tuesdays, we know exactly how many people and who's been vaccinated. And so on Friday, we're letting people know what's up in their city. And that to me is, that is human rights, right? Like it is their data. They should be able to make decisions about their lives and their health because they have access to the data, and it's not hidden in some obscure journal that then the people who are affected by it don't even understand what it means. And that to me has been the funnest part, is actually making it very real.
Thank you, Chris. It does remind me of kind of like some data to the people efforts that have really happened in epidemiology, especially over the course of the past year. I wanted just to open up the discussion, and Dr. Mary Bassett made a comment that this is a case study in good public health practice. And can you, go ahead. Do you want to go ahead, Mary? I don't know if that.
Yeah, no, thanks. That's exactly what good public health practice is, and it follows the social science evidence base as well. that people need to have the opportunity to ask to air their legitimate concerns and have their questions addressed, that access is critical, and that bringing vaccination to people is probably the lowest barrier access you can have, and targeting your efforts, which you were able to do with the wastewater. So it's really brilliant, and it reflects the partnership that Chelsea put together. And that would be interesting to reflect on what enabled Chelsea. Was it the terrible experience of so many people to have such an effective partnership? Because that is something that guidelines never can create. And then I had a specific question. You highlighted, I think you said a FEMA clinic, and I wondered whether somebody could explain why that was so important. I'm guessing that it may have had something to do with a high proportion of undocumented people who didn't have other healthcare access. Thanks, and I'll mute myself.
Yeah, there's two. When vaccination started in Chelsea, the East Boston Neighborhood Health Center opened up a vaccine clinic at the offices of La Colaborativa, which are right next door to the post office on a main street. The issue with that was the appointment system that I explained, and that it's always been by appointments. Like even now, even though we do have on the ground appointment making, you still have to make an appointment. One of the issues with making an appointment is that somebody from East Boston Health Center will call you and say, do you have health insurance? And then when you come, you have to show an ID. And as much as we tell people you can say no, it freaks people out. It really scares them. And we have had people say, they asked me for health insurance, and so I can't get a vaccine. The understanding is you don't have the right to it. And so what happened with the FEMA clinics was that FEMA clinics are walk-in, and we have two systems. We have a walk-in system, and you can also make an appointment. Some people like to have an appointment, and I always think about moms with small children, because you're thinking like, okay, if my sister can watch the kids for 3 hours and I can run go get my vaccine, your life is kind of crazy. And Chelsea is it's a young city. Most people are young, and most people do have, in my research, the average number of children is almost 3, which is high for the US. And so the FEMA clinics are open Friday afternoons, Saturdays, and Sundays. And they allow people who have jobs to be able to just jump in and get a vaccine. We also now have the mobile units. We had a couple vaccine sites at Emiliana Fiestas, which is where we used to do the testing, which was like a party hall. And now 318, which is the East Boston Neighborhood Health Center, is getting more flexible about walk-ins, because they're seeing that there's a lot of competition. And we also encouraged East Boston to open 2 evening clinics on Mondays and Thursdays, because there's people that work 7 days a week. And we also wanted to make sure. So we're constantly listening on the street of, are you able to get a vaccine? And if not, why? So then we can go back to the clinics and say, we need you to do this, so that people can actually get their vaccine.
Thank you, Chris. I think that also speaks to the implicit messaging that happens when you ask people for insurance and IDs, which are not required, and it's been very clearly stated by our Attorney General in the state. But still, the just by being asked, there's a lot that's implied with that. And it looks like that there are a couple of folks with questions, and we'll start first with Julia. You have your hand raised.
Thank you so much. And I want to applaud Chris and all the members of this project for fantastic, amazing work and for saving lives, which is what it's about in the end, what it comes down to. I put some points in the chat. I'm not a public health person. I'm a pediatric infectious disease. This is not at all my day job, but I have been engaged in immigrant health and immigrant rights in Massachusetts for a while. I've known La Colaborativa since we did a project for the so-called unaccompanied minors in 2015 and 16. Long story short, I think it's about power more than anything else. And the reason Chris and the whole team can be so successful is because of the power La Colaborativa has built to that point, our governor, who vowed and did veto any pro-undocumented bill in the legislature ever since he came into power, and told the state police to collaborate with ICE, has not been supporting public-based efforts like through the public health boards, but rather has farmed out the whole vaccine response to for-profit entities, and so has been paying the promotoras that work with La Colaborativa through this entity called Archipelago Strategies Group, which is a for-profit marketing company. My perception is that their mode of doing things has had a harmful impact, and I'm wondering if there is another way that you see to bring this money to Chelsea and to pay the promotoras outside of that ASG, because basically they treat the work like you know, a factory would treat its workers, and I notice, you know, harmful impacts on the work of the promotoras. Sorry to be talking.
Thank you. That's okay. Thank you so much, Julia. And I'm going to, Stephen, before we get to your question, which I promise we will, I'm going to pivot just quickly to Karthik, who has a couple points about your comment, Julia.
Yeah, I was intrigued by the way you phrased it, and as a conversation about power. For somebody who works in clinical medicine with machine learning people, I was just very intrigued. You know, Chris mentioned that, you know, we have a meeting on Fridays where we just get together and brainstorm. But what she didn't say is a lot of times the most rewarding conversations have been these post-dinner Slack conversations. You know, everything from vaccine prioritization and so on. And it just struck me that it seems like because we are so governed by the clinical lens, the clinical way of looking at everything, clinical lens-based way of evaluating risk for a person, risk for a group of people, etc. And all the airways, if you just listen to the conversations on Twitter, if you switch on cable news channels, it's mostly a bunch of very well-meaning people with MDs going about giving advice and in charge of messaging. And it seems like the concept of community risk is not at all present in the American public health psyche. You know, just as a lay observer who's not in public health, whether it is vaccine prioritization, the science clearly told us that vaccinating everybody in Chelsea very early on and having a different eligibility criteria would in fact reduce the risk for every other person in this part of the state. And that's, you know, if we were governed by community risk, that would be followed. Diagnostics, we've always been very narrowly focused, I think, on these very highly sensitive RT-PCR tests, which, you know, like the FDA is fully in charge of diagnostics. There's just a not much thinking that has gone into how can we increase surveillance at the public health level, even if the tests are not as accurate as, you know, a diagnostic RT-PCR. So when we talk about power and we talk of, you know, how we calculate risk, it just seems like community risk versus individual risk, with individual risk completely being dominated by this clinical lens, is for me the biggest glaring power differential that I see. I just wanted to point that out.
Yeah, thank you, Karthik. That's actually a helpful way to frame it. And I want to turn to Stephen and make sure that you get an opportunity to ask your question. Go ahead, Stephen.
Thank you, Maggie. I would like to pose a question linking the observations by Julia and those by Chris on power and human rights. Chris quite rightfully, of course, pointed out that, Julia quite rightfully pointed out that it's essentially a question of power relations, and Chris and indirectly Mary as well noted the direct implications for the realization of the human rights of the affected population. So my question is whether or not this awareness of inequalities, lack of access to health, lack of realization of the right to health, the right to benefit from advances in science and technology, and all of the right to food and all the other human rights implications involved, whether this experience that has enhanced people's capacity to realize their own human rights has any lasting effect. Will in 1 year, 2 years, 5 years, Chelsea be functioning better in readjusting power relations in the interest of underprivileged populations and having mechanisms whereby people can find a path to realize their human rights? Thank you.
Yeah, I think what people really should understand is that that the power structure in the city is broader than I think what maybe people realize. I mean, in the news, you hear about La Colaborativa all the time. There are other organizations in the city that are involved in ensuring that what you just mentioned happens. I recommend that everyone Google Robert Wood Johnson Foundation Chelsea, and you're going to see we were a Cultural Health Prize winner a few years ago. There's a 10-minute video that I think encapsulates the beautiful collaborative work that happens in the city prior to the pandemic. So when the pandemic hit, if you take a look at, and Mimi Graney can share she accumulated all the news stories, articles and whatnot that happened nationally. We're talking about national and actually global coverage that people were speaking about the very things that you're talking about and how that's important. The residents of Chelsea are driving the Boston economy, the greater Boston economy. Their essential workers are going there. And then also Chelsea bears the brunt of a lot of the reasons why this region is powered. The storage of oil and fuel, diesel fuel for the airplanes. The pollution that we get being next to an airport. I mean, all those health disparities have impacted the city for a long time, the salt pile that we have in the area. And people have literally dumped on Chelsea for decades. And in the past 5-10 years, obviously La Colaborativa, Green Roots, Roca, T&D, they have all come together to say enough is enough. What the pandemic did is it gave us greater voice. So that the bullhorn that we had was this big, but when the pandemic hit, it became this big. And everyone caught wind of everything that was going on. It didn't just happen during the pandemic. It's been going on for years. And, speaking of power, our city government is who empowers us as a Chelsea project to basically give him guidance, our city manager, right? And there's a reason why we have a city manager. If you want to, Google 60 Minutes Chelsea Mass, you'll understand why. It was at one point the most corrupt city in the country. And it's a city that's been traumatized for decades. And right now it's a beautiful, beautiful period for the city post-pandemic. And I invite you all to come on down. Mimi and I will be happy to show you around the city and take you to some of our favorite places to eat. But the power structure that exists is based on collaboration.
I just want to add on to what Dan's pointing out about Chelsea and all of the existing entities there. I also want to say that this project team has actually talked a lot about how do we make some of the programs and changes we've made permanent, because we do feel like, yes, our work has been focused on COVID, but we also want to be moving towards a direction of building a culture of health, of public health, and the same along the lines of what Karthik was talking about, this emphasis on community risk rather than just looking at individual risk. So we have started talking about things like, for the Promotores program, are there ways to make that a pipeline for jobs for people long-term, whether that becoming like a health community worker for MGH or Beth Israel hospitals, which are both have offices located in Chelsea. So we definitely are thinking about how to make some of our work more permanent, because I agree that, like, how do we make sure that Chelsea ends up better off in the future than where they are now. So
Thank you, Sam. I think that that'll be really the test for a lot of organizations and a lot of projects right now, is that any innovation or success that was had in the past year, how can that be leveraged into something ongoing and sustainable for the future, and not just kind of pocketed and looked at in the rearview mirror as something that happened during the pandemic. I see another hand raised. There's Sarah. Do you want to go ahead and ask your question?
Yeah, thank you. It's really great to see all these people coming together. Hi, Dan. I'm a Chelsea resident, and I also am a PhD candidate at Boston College School of Social Work. So this is like a, merging of my passions. I was thinking about, I think what Dan was saying earlier about how the Chelsea Hub model and the Chelsea Project model are have so much potential for other social issues beyond the coronavirus and COVID. And I was wondering what you all think, especially Dan, what the most urgent next problem will be, or the best opportunity for the next issue to tackle with this model, especially as I think about how I, merge my academic interests and my community engagement here in my local community.
I'll be brief. So one of the things that we're learning is that other communities do not have these infrastructures, right? We get calls daily to help communities start their own Chelsea Hub, their own hub models, right? And what happened in Chelsea is we, in January, when the moratorium was going to be lifted, one of our colleagues, Alex Train over at the city, said, listen, we need to do an eviction task force. So we modeled that actually loosely on the hub. So everything has this introduce a situation, everybody mobilizes, go out and do the work, and then come back the next week and update each other on your progress, right? So the eviction task force is set up very similarly to that. And I will tell you that we do great work with the hub, but the eviction task force in the past few months has been an all-star group. And it's organizations that are there. They have their pots of money. We're putting people in hotels until we figure out what we're going to do with them. People are being housed in Chelsea at a rate I can probably guarantee higher than anywhere in the United States. And it is actually switched from eviction. It's gone from eviction to homelessness. There are people that are just homeless that are showing up, and we're just taking care of them on a regular basis. That happens because we meet on a regular basis. That said, these systems, these forums are applicable to any situation. So what we're going to do is take a look at how we can help communities, not just start hubs, but to create partnerships like the ones that we have, not only in the Chelsea Project, but others, and do great work. And not every community is blessed to have a La Colaborativa or a Green Roots or a ROCA or a T&D or city management the way that we have, and staff like Mimi and Alex and others.
Also, Sarah, just so you know, so we've started designing monthly campaigns on the ground. So for example, for June, the campaign is Chelsea Seguro, which is health insurance. I found in my research that 10% of Chelsea residents didn't know if or knew that they didn't have health insurance. And so, so for June, on top of everything that the health promoters are doing and that we're already doing, now we're starting to layer things on top of that. So our first layer is everybody has the right to health insurance, and this is how you get it. So we're going to start layering that. We have, we want to do for July, we want to start talking about mental health. One of the things that I found in my research again was, who hasn't been traumatized by this, on top of everything that people, we've talked about for the past hour, everything that people are already going through in Chelsea. But I also found that access to psychotherapy in a medical institution is very, very low. It's not culturally appropriate. It's not, there's a lot of reasons why that's not working. So, again, this is where we're going to start outreaching, the caseworkers that Dan's talking about that work on the eviction task force. They're experts in mental health, and starting to figure out how are we going to replicate this model to start to address the other social determinants of health and start talking about them. Because we feel that the work we've done with COVID and vaccination is rolling, and we want to keep it going. And now we can start layering other stuff on top of it. Yeah.
Thanks, Chris. I didn't know if anybody else on the panel wanted to respond, but I think that point about even the system and model that we have for mental health in this country, and even what access is here in Massachusetts, doesn't necessarily mean that it is truly accessible to people, or that it's necessarily appropriately offered in the way that is meaningful for people to utilize. And so I think that one of the things, almost kind of like, I feel like the next frontier in this pandemic is trying to figure out how to improve access to mental health that's actually meaningful and significant for community members in a very different way than this appointment-based system, and this usually high threshold of you need to schedule an appointment, it's going to happen in a certain amount of time. You have to have like 2 or 3 appointments with a counselor before you get to see a psychopharmacologist or a psychiatrist. And so there's just a lot of built-in barriers to behavioral health care.
Maggie, just a quick point to that. So part of the data that we get out of the hub, which is all de-identified, it tells us what the highest risk factors are. And mental health is, over the past 6 years that we've been doing the hub, is the #1 risk factor. We didn't have any mental health representation in the beginning. Now we have a robust effort from North Suffolk Mental Health, Elliott, and DMH. So not only do we have quick access to mental health services as a result of that, we're utilizing that throughout the eviction task force and other, the case managers that the La Cooperativa works with, the people that they work with as well. One of the things that we did is we took some donation of need money from Beth Israel to fund a special program that funds underinsured or uninsured people that are predominantly immigrant from the immigrant community, to provide them instant access to mental health and wraparound services. And that has been a highly successful program. That resulted out of everyone realizing what you just said. So why don't we get that power in place and get the funding from an institution like Beth Israel, Mass General as well, and provide it into that really common sense approach, right? Give the resources to the people that desperately need it.
Thank you, Dan. And I know that we have about 2 minutes or so before we end. And I just wanted to ask if the panel wanted to share any concluding remarks, or I'm happy to provide a little observation, but I'm much more curious and interested in hearing what you all have to say. If you want to leave us with any final thoughts or comments.
I think one thing I would like to just share, I know that our work is very public health focused, but our Center of Complex Interventions, we really see this combination of interdisciplinary work, the practice of actually being on the ground and understanding the context of a system that you're dealing with, but then also, combining it with the latest science and research. That philosophy really can be, I think, applied to a lot of different problems. So I would just encourage, like, any project that anybody's working on, I think there's a lot of themes and lessons from this type of work that can be applied. Where our organization's even looking at things like climate change. How can we draw from this work and apply it to another complex problem? So I would love to hear from anyone who's thinking about these issues, and yeah, lots to learn.
Thanks so much, Sam. And I don't know, Chris, if you'd like to take us out and just offer any kind of concluding remarks. Thank you so much for bringing everybody together today. And if you just want to send us off with some final thoughts as we end.
Well, thank you, everybody. It's also been really great to see who's come to today's talk. You know, just having Mimi here is always very special. Mimi also came to my defense. So I feel like that, you know, just always having you here is great. And also Dr. Marks, who asked the question, he's a human rights specialist on the international front. So, you know, being able to have that conversation across, you know, across the different spaces. So all of you who are here today, I think you're here because, you know, the FXB Center is a place where we come together and say, I do this random stuff, but if I come together with somebody who doesn't do what I do, I might get a different perspective. And I think that, you know, I really enjoyed, you know, being in a space. And I think, you know, we've all talked about how much fun it is to be in the Chelsea Project. And to me that, you know, I mean, that's part of our own healing from the pandemic, is being able to really, truly enjoy our work and believe in it and know that what we're doing is making an impact. Because then we walk around and we embody that joy and that vision. And that really just coincides with the people that we work with in Chelsea who do. I would absolutely say Chelsea is a place of joy and vision and persistence. People who live in Chelsea love being from Chelsea. They're very proud of Chelsea. And so it's really just an honor to be part of that circle. So thank you, everybody. And thanks, Maggie, for facilitating the conversation. Always a joy to see you too.
Yeah. Thank you so much. That's a wonderful way to wrap up on the strength that exists within the community of Chelsea. So thank you, everybody, and for your time and participation. We'll have this works in progress session recorded if anybody would like to reach out for the link afterwards. Thank you and have a great rest of your afternoon.
Thank you.